Well, good afternoon and welcome back, Aggies, to campus for the spring semester in 2022. This is our first town hall meeting of 2022, and I trust it'll be informative. Really, it's to help get you acquainted with the latest information that we all have regarding the health conditions of our community and beyond, and a little bit about how we will at NMSU essentially manage through this next phase of the COVID crisis, so to speak. Let me start where I think many of you have already kind of concluded. You know, as we hear from more and more professionals, certainly everybody's paying close attention. We're getting certainly a very strong impression that what we originally thought that the COVID crisis or COVID pandemic would come and go and be done. That's clearly not the case. Here we are 2 years later after having really gone through some significant challenges in preparing and being able to manage in this kind of an environment. And it looks pretty much like this is more like what we are going to have to expect going forward. This is not going away anytime soon. Certainly certain things are changing that make it perhaps a little bit more manageable. We have a new set of tools. Since the first time we had one of these COVID town hall meetings, the most important tool that we have, of course, is vaccinations. We're very blessed to have had the technology and the ability to go ahead and develop those vaccines in record time. And so now it's really about how do we manage our behaviors in this context and really doing all that we know how to do to keep ourselves safe. So first and foremost, being vaccinated. The second is really I'm going to put it in the category of personal responsibility. We're hearing all these things, and you're going to hear from our COVID action team and all of the other stakeholders that we have that give us guidance and new information about how to manage within this environment. But what we'll learn very, very quickly is that there are certain things that you just have to be paying attention to. And let me just start with the most important one, and that's one that kind of hits close to home. And that is, if you have family members or dependents or people at home or people that you really care about and that you see frequently, and they are autoimmune compromised, then that takes a different level of care than what you have maybe even for the rank and file and what you'll hear in terms of our protocols for the institution. My spouse is autoimmune compromised, and so we've had a lot of very interesting discussions over the course of the past several weeks. And now that we have this Omicron virus surge that's going on right now, you'll learn more about that here in the course of this conversation. What I'm detecting is that I have to be especially careful. Even though I may be less at risk because I'm vaccinated, I'm boosted, I'm in relatively good health, although my age is a risk factor. The other thing that I've got to be careful about is, even though I may be exposed to the virus and be able to carry it asymptomatically or maybe with mild symptoms, there are people in my immediate sphere at home that would be more compromised and would be very, very vulnerable, and they're in the higher risk category. So I have to treat myself as though I'm in that high risk category as well. So I just wanted to highlight that particular point and bring that home perhaps a little bit more personally, because it is something that we all care about. Now, that said, the other piece of this is that, for the most part, I think what we've learned is that this idea that we have to kind of learn how to work within an environment like this one is really important. Some of the numbers that I've recently gotten at least updated on is in Doña Ana County, we have about 80% of our population that's vaccinated. On our campus, we have 97% of our employees are vaccinated, and our students are 89% vaccinated, 99% compliant, I might add, because we give them the option to test. So we have essentially, I think, met most of the needs that we're talking about in terms of those responsibilities. And we have to weigh in the context of a university how we actually manage that risk, the health risk that goes with that, in the context of how can we also continue to provide the educational opportunities that we have committed to do. And specifically, we're recognizing that the downside of educational disruption also has a fairly significant consequence in our communities with the mental health and a variety of other things. So we have chosen this path. It is the path, I think, that most universities in the country are following. About 10% of the universities that have been polled essentially are starting either in a remote kind of mode or are delaying their start. It's a very small fraction of the overall. So I think what we're recognizing, we like a lot of other people, is that we have to learn how to work within this. So that's a recognition that we've got, some challenges in front of us, but also we've got some tools. We've got the tools of, as I mentioned earlier, vaccinations. The second big tool, and the one that I think, again, as a matter of personal responsibility that we need to focus on, is a well-fitted, a mask that has the NIOSH rating, the KN95 or KN94 and 95s, I think, are the ones that we're focused on. And we want to make sure that we have both well-fitting masks and then people wearing their masks in an environment where they have close proximity to others, and that we're not quite sure what their exposure status might have looked like. So I think we're going to continue, recognizing that there are some glimpses of evidence that suggest that on the East Coast coming west, there might be some drops in the Omicron variant spread or surge, but it's not here in New Mexico yet, and we need to be ever vigilant. Hopefully, that'll also we'll get that same experience here, and then we'll be looking at how do we manage going forward. So I'm going to stop there, but primarily I wanted to say welcome back. We're in, I think, a mode where we, I believe, are managing the risks in a balanced way. Obviously, we will continue to monitor the conditions, and as the conditions change, then the protocols will change. And so just be patient with us and recognize that we're trying to balance all of these things at once. Once again, if you're autoimmune compromised, you got an extra level of vigilance that you got to really adhere to. So with that, I'm going to turn it over to, I think, Vice Chancellor Dr. Johnston will take it from here. Again, Aggies, we're impressed with what we can do as Aggies, and we'll look forward to a good semester going forward. Dr. Johnston.
Thank you, Chancellor. Welcome to spring semester, Aggies. Hope you're all safe and had a good long weekend and celebrated the legacy of Martin Luther King and stayed safe and distanced. I'm going to do some kind of high level stuff, and then as usual, turn it over to Jon Webster, who's going to show us the dashboard. And then we have also Renay Scott, Amanda Blair, and Kathryn Hanley, who are here to help answer questions. This one's a little bit different in that we're also having a presentation at about 3:45 led by Lauren Goldstein, who works with us here in the Chancellor's office, Professor Jagdish Khubchandani. Sorry about that, Jagdish. I know I didn't say it quite right. And we also have our HelioCampus colleagues who are going to do a short presentation on discussions about trends in academia, trends in student mental health and wellness staffing. We know that many universities have chosen to stay open because of the incredible need that students have to be in person, to have some social connection, and to work directly with faculty. We don't take these decisions lightly, let me tell you. We're constantly talking with each other about what's the best thing to do on behalf of our students. Also of note, the Teaching Academy, for those who are interested in the mental health aspect, is holding a Supporting Students Mental Health panel discussion Tuesday, February 22nd from 1:30 to 2:45 via Zoom. And we'll provide additional information for you on that in the Now News coming up on Thursday. Additionally, if you've got questions as we go today, please send them to covid19@nmsu.edu. We won't be able to probably answer most of those today, but we assure you, you will get your answer like we do to everybody who writes in. So now to some of the highlights. I'm sure some of you have read, and Chancellor just said, that we're finding on the East Coast and also in Europe that the numbers for this variant are reducing. We sure hope that's going to be the case for New Mexico. And John will soon show you the data that we have on the positivity at NMSU, both the main campus, but also the other campuses at the community and the state. The state changed the way that we have to report our data. Rather than Excel pieces of paper that we had to fill out and send up to the state, they decided to put together a much easier to use web-based system. However, reporting was very, very difficult to get. And so towards the end of last week, when we weren't able to report for a day or two, Jon Webster was in the background talking with Aggie Health and Wellness, talking with the state, doing what he needed to do to try to make sure that we got the numbers so that we could put them on the dashboard, which they were again on Friday and will continue to be every day as much as we can get the data. So we're happy about the way the data transmission has changed, but it's made it a little bit more challenging for us to report to all of you. You may have also heard in the New York Times on the 16th, there was a long article about COVID in colleges, and they said that a number of colleges have simply decided not to report data any longer. And it's not just the states where there are different issues in terms of politics, it's states in general, because really what they are reporting, if they're reporting at all, is the vaccines. And how many people are already vaccinated, because that's really the telltale tool that we have to try to prevent the spread of the virus around here. But we are not going to follow suit. We are going to continue to have a dashboard. We're continue to want to inform you as much as possible because people want to know, and we agree that we want to share what information that we can get. Again, realizing that we're not working alone here at NMSU. We are working with HED, we're working with the Department of Health, we're working with the federal government and the CDC. So living with COVID is what we're doing now, but we have more tools than we had before. And we know that there's concerns. We've got concerns for students, we've got concerns by faculty, we've got concerns by staff. None of that is new, but as you heard before, the percentage of vaccinated is very, very high. And as long as we wear our masks indoors and stay socially distanced from other people, we know that that will reduce the spread. So that personal responsibility that the Chancellor encouraged is absolutely critical. We also have ordered 10,000 K95 masks. Those will be delivered to the main campus vending machines as well as the classrooms. And I know that the community colleges are also doing supplies. We know that the medical grade masks are better than cloth masks. However, if you double mask and make sure that your nose is covered at all times, and if you've got one of those masks that keeps slipping, get a different mask. It's really important to have that complete coverage of your nose and your mouth. You probably also know that the CDC has altered its guidance about quarantining and isolating. And as usual, we follow those guidelines. So the quarantine has been reduced from 10 days to 5 for people who've been exposed. And the self-isolation has been reduced from 10 to 5 for those who test positive for the virus, followed by 5 days of masking indoors around others. It does not say that you have to test between those 5 days of self-isolation and 5 days of masking. However, regardless, if you have symptoms, stay home until you feel better. And there's all kinds of stuff going around. We had visitors at the holidays, and the man who was visiting got a test. He had a cold. He thought he had a cold, but he wasn't sure, so we went and got tested. Please go get tested. Curative's still out there in the parking lot on the main campus. It's at the Mesa campus, and for the community colleges, it's at various places within the community. We still require masking indoors, and we need to help each other sometimes. Only when you're taking a little sip or a little bite should that mask come down. Otherwise, it should be firmly around your nose and your mouth. Some of you have asked if we're going to change our guidance for vaccine requirements and boosters. We are not. We are following the state mandate, and we will continue to do that. It's very, very important that all of our employees get not only vaccinated, but boosted when the time comes. John will talk about that in a minute. And of course, the students have the opportunity to either do vaccine with a boost when the time is right, or the weekly testing. In addition to the testing resources on the NMSU Now website, and I encourage you to be looking at that fairly frequently, the Biden administration announced this last week that insurance companies are required to cover the cost of tests up to 8 months per individual. There'll be more information about that in the Now newsletter again this week, as well as how to get your 4 free family kits from the U.S. Postal Service. But I got to tell you, there's already some supply chain demand, and you may not get them as quickly as you need to. The state requires, for those who are doing testing, maybe because you got an OIE exemption, that you have to be visually watched through the vault in order for it to be appropriate and accepted. The at-home kits that you're going to get from the federal government or from your insurance are not going to be appropriate unless you're actually watched by vault. So we'll share more information as we go along. Dr. Renay Scott, our acting provost, is going to address some faculty-related teaching questions. I know that there is a number of questions that are out there, but we increasingly hear from our students that they want that in-person experience. And just so you know, this semester at the Las Cruces campus, about 1/3 of our classes are fully face-to-face, 40% are hybrid, and 21% are fully online. So while we don't have a full range of classes face-to-face, we do have more than we did last spring, which is when it was only 12%. I'm here on campus today, and as usual, I walk around the campus, and it's really fun to see the buzz. People are talking to each other. They're staying socially distanced even outside. I think we've all kind of gotten used to it. And I would say walking around that people are probably half are wearing their masks even outside, and half of them really aren't. So we constantly watch data. You all probably don't know how many people behind the scenes are working on COVID every single day, all the time. We look at the data, the hospitalizations, the residence halls positivity. We make sure that the FNS staff are super involved and cleaning daily. The ventilation is looked at all the time and the filters are changed. I don't know how many of you go into Taos, but I was there on Saturday doing a prospective student tour, and they've adjusted their setup and reintroduced the barriers and the pathways to assure distancing. So I would say everybody here is doing the very best they can to keep each other safe. In addition, though, it's really our own personal responsibility for taking that so seriously. And last, just so you know, COVID CART meets every Wednesday morning to talk about the latest data and research, and we make constant adjustments. And you'll see in John's slides in a minute here that there's some triggers that we look at every time to make sure that what we're doing is the best thing that we can do on the behalf of our Aggie nation. Chancellor memos, hotlines, Now newsletters on Thursdays, lots of communication. And of course, please do send your questions in, because it's a constant monitoring and responding to all of you. And your questions often provoke us to find out more so that we can answer even better and help others learn more about the COVID and what's going on. So now I'm going to turn it over to John to go over data, and then we'll bring our panelists on to answer questions. Thank you, John.
Thank you, Dr. Johnston, and good afternoon, Aggies. Let's go ahead and get started with some of our data as mentioned. So we'll take a look at our weekly Aggie COVID trends report. This report is updated for the daily CART that Ruth mentioned tomorrow morning, and then will be posted on our dashboard for all to see. So looking at positivity comparisons, our New Mexico, and all of these as are of late afternoon on January the 14th, last Friday, because the state has not released data today yet. So our 7-day positivity rate for New Mexico, 20.4%. Doña Ana County 7-day positivity rate is 25.9%. And our 7-day per 100,000 people cases per 7 days is 259.5. For New Mexico, for NMSU though, our 7-day, we do a calculation of our 7-day population rate compared to the Doña Ana County numbers reported. 4.6% of our positive numbers make up the Doña Ana County positivity numbers. Now, here's what that breakdown is. From last week, Doña Ana County reported 3,808 cases. That's minus the 175 that NMSU reported. Doña Ana County had a 1.74% population positivity rate. And here at NMSU and Doña Ana Community College, we had a 0.7% positivity rate. That's 4.6% of these numbers reported for Doña Ana County. Why is that number important and why is it green? We make up approximately 13% of Doña Ana County's population. So in order for us to make sure we're not giving more than our fair share or creating a health risk for the county, we must maintain below 13%. And as you can see, we are well below even with the accelerated reported numbers. So trend lines for the state and both Doña Ana County, we all know that our numbers are very high. You can see the spike at the trend on New Mexico and Doña Ana County. But as reported before, NMSU, we've seen the same kind of increase in numbers for both our students and our faculty and staff. But our numbers compared to the county were product of our surrounding environment with much greater success. Level of community transmission for the United States. The entire United States right now is fairly high. Not a whole lot to say right there. We know the transmission of the Omicron variant is high right now. Let's talk about good news with all of this. So although it's not all good news, what is good to note is, as you heard Dr. Johnston mention, we have triggers. And this is one of those that I want you to pay very close attention to. We watch our hospitalizations in Doña Ana County. So Doña Ana County right now has about 17.5% of all its available beds in all of our hospitals with COVID patients, 41.41% in the ICU. So we do not have anywhere close to 50% of all beds available, and we have almost 9% less in our ICUs than the 50%. Why is that important? It's very important to note that there's no surge capacity been enacted in Doña Ana County. So our numbers continue to fall on hospitalizations, and that's very, very good news as it relates. Vaccinations are important. So let's talk about vaccinations. So these are our mandates that Dr. Johnston mentioned, and you heard Chancellor Arvizu mention. All employees, including student employees and those who are teleworking, were required to either submit proof of vaccination or request an accommodation by January 4th, 2022. We are following currently our state mandates and directives from both the New Mexico Higher Education Department and the state of New Mexico. We also fell in line with the booster mandates. All employees, including all student employees who are teleworking as well, are required to receive a booster by February 9th if eligible. Let's talk about February 9th. February 9th is when our mandate goes into effect. Not everyone may be eligible at that time, and that is the key. You are either eligible for the booster and you receive it, or you wait until your eligibility and receive it, or opt to test. So here's an example. If a person received their second dose of Pfizer on December 15th, 2021, they're not eligible to receive the booster until May 15th, 2022, under the current FDA guidelines. So we also allow a 4-week grace period because you cannot register for the booster until May 15th. So that means that you would either decide, are you going to get boosted by the week of June 12th, or you can opt to test weekly that would not begin until June 12th. We're not saying that by February 9th, everyone has to test. We're saying you must only test if you're eligible for the booster and opt not to receive it. So there's another caveat to testing that I want to make sure is very clear. If you opt to test and you test positive, there's been many speculation about what does the 90-day exemption period mean. So 90 days, the CDC and many health organizations recommend you do not test for 90 days because you can create a false positive in that test. So you enter that test into VaxTrax. It starts your 90-day exemption of testing right then. So you also, as an individual, you should know when that 90 days is, but you're not required to submit a test for 90 days due to the fact that you could create a false positive. As I mentioned earlier, we'll go over this real quick. NMSU, our administration, we are very committed to watching all activities in our surrounding community and knowing what our triggers are. Trigger reminder, positivity rates of our COVID-19 calculated by population that are higher on any of the campuses than in the county in which they reside. Here in the main campus in Doña Ana Community College, as I explained earlier, currently 4.6%, and it's less than that 13% of our makeup of the county population. Also, our local hospitals approaching capacity for ICU beds. We are not close to the capacity for ICU beds from COVID. Currently, 41.4% are all that occupy ICU for COVID with no surge capacity enacted. Another point to make on why are vaccinations important. So this is a graphic, came out from the New York Times, reported on Seattle area hospitalizations from November 15th, 2021, and deaths from November 15th, 2021. You'll see in the first graphic, it represents that unvaccinated individuals make up about 10 hospitalizations per 100,000 people on a daily average. Vaccinated individuals make up about 1 or 1.5 of 100,000 people daily. Deaths, fully vaccinated, not fully vaccinated individuals make up about 1 death per 100,000 in the Seattle area. And the line remains flat for those that are vaccinated, very, very minimal out of that 100,000. So vaccines are important. We still encourage everyone to reach out and get their vaccine. So with that, I will stop sharing and turn it back over to you, Dr. Johnston, for your questions.
Thank you, John. And if Amanda and Kathy and Renee would come back in, thank you. Some of you may be new to coming to these, so you don't know who we all are. So let me do a quick introduction. So Jon Webster is working as the COVID Project Manager and is kind of my right-hand person. I'm Vice Chancellor. Renay Scott is Acting Provost, as well as the Vice President for Student Success. Amanda Blair is interim responsible for Aggie Health and Wellness. And Kathryn Hanley is our expert. She's our professor, virologist, and all things research, and helps us tremendously answer all kinds of questions. So I want to thank all of the panelists, and I'm going to jump into questions because we've got about 20 minutes before we do the second part of our session. So thank you all very much. So the first question I'm going to send to Renee, because John's been doing so much talking, which is instructors should, if students are not wearing their mask properly, covering their nose and their mouth during class, what is the protocol for instructors?
Thank you, Dr. Johnston, and Kathryn Hanley's got it perfectly displayed for us. You know, what I find interesting is as professors, as teachers in the classroom management has always been kind of part of our job. You know, the pandemic and the required masking has made that one more item that we as instructors need to focus in on. You know, my recommendation for faculty is that if there is a way to discreetly point out to the student that they need to get their mask to cover their nose or to cover their mouth, you know, so as to not interrupt the flow of the classroom, that would be my first advice. Again, all pedagogy and classroom organizations are different. And so you may find that you may have to directly instruct the student, you know, could you please, you know, put your mask on, adjust your mask accordingly. I also would say that, you know, it's not a bad reminder at the beginning of class as you're all getting settled in to just a general reminder to say, hey, I just want to remind you all to properly wear your mask. I do want to point out that the university has updated some of its signages on mask, and the mask signage points out that it should be over the nose and under, you know, over the mouth. And I think that signage helps as well. Thank you, Dr. Johnston.
Okay, thank you. I'm going to do another one for you, Dr. Scott. Is there a chance for campus to be closed again or be sent home to telework?
You know, I don't foresee that possibility. I think, you know, you've heard the chancellor and the vice chancellor and even John reference the fact that, you know, I think we're in a new time in our lives. I think we're going to have to learn to live with COVID. And we know that with this variant, that Omicron is certainly very transmissible, but I'm not foreseeing that possibility. Having said that, Jon Webster just shared with you the triggers, and those triggers will be things that we continue to monitor. And so while I will never say never, you know, it is our commitment to try to learn to live with the new situation as we find ourselves in. But if the triggers present themselves, we will make the appropriate announcement for the university as necessary.
Thank you, Dr. Scott. And, you know, I would like to add that, you know, we have the alternative work arrangements for the staff. If you all decide that you want to reduce the density, then you might want to talk to your supervisors about that. We really know that people want to be, at least at some level, back on campus interacting with people. So we're not planning to go fully online. We don't want to go fully online or fully telework, but we're not, we're really smart. I mean, we're working really, really hard, listening to all the data, all the variety of data. You know, they don't always agree with each other. So it's important that we read the bad as well as the good, as well as the conflictual information, to make the best decisions that we can on behalf of all of you. And you do help us with your our decision making, because you send in really good questions that we pursue. Okay, John, this one's for you. Does the Supreme Court ruling to deny the OSHA mandates affect NMSU policies?
Simply put, no. But let me clarify just a little bit. The OSHA rule was overturned, but we have been mandated, and we have full support and directives from both the state level and the New Mexico Higher Education Department, New Mexico Department of Health, and the governor's office. We are maintaining course with our full vaccination deadline of January 4th and our booster mandate, which falls directly in line with also with the state employee mandates.
Thank you. So what happens if you are in a classroom that feels too crowded, whether you be a faculty member or a student? Dr. Scott?
You know, that's a great question. And, you know, the CDC has changed some of their guidance in terms of what's the term of exposure and the social distancing. You know, I think it still comes down to wearing masks and wearing them properly. You know, ideally an N95 or KN95 mask is certainly better at keeping transmission down. Instructors, I encourage you to keep your 6-foot distancing when all is possible. If you really do think the classroom is extremely crowded, please work with your department head. You know, as Dr. Johnston mentioned, that roughly 38% of courses this semester are face-to-face. That would seem to suggest there might be larger classrooms available. Again, it depends on the size of your class, but the department heads working with the colleges for room scheduling or with centralized scheduling out of the University Student Records Office, if it's possible, we could find a different classroom as well. Be vigilant with masks. And I hope you're all vaccinated. That clearly indicates that vaccination is a way of lessening the impact of COVID to you as an individual.
Thank you, Dr. Scott. Dr. Hanley, do you want to add anything to that, being a professor in a classroom?
Yes, so I am eagerly awaiting the delivery of our KF94 masks, which are these. But in the interim, I paid out of pocket and bought my entire 50-person class, a couple of these each, so that we could bridge the gap, because I think these masks are by far and away the most important thing that you can do to avert classroom-based transmission. We know actually that vaccination, while it's critically important for minimizing illness, is not helping as much in protecting against transmission with Omicron, but a properly fitting mask absolutely does. And so far more than social distancing or wiping down surfaces, having that mask on at all times is really important. So I don't permit eating and drinking in the classroom so it's simple. So people just keep the masks on. They're welcome to step out if they need a drink of water. And I proceed every class with a reminder that I need those masks over everybody's faces and noses. And I can see them all, even if they sit in the back of the room, they are still visible to me. And they have gladly complied. It's a virology class, so I may have a very ready audience there, right? But really keep those masks on, and that's going to minimize transmission.
Thank you, Dr. Hanley. And a little follow-up on that. You know, there's a lot of people who write in and ask us, well, what about testing everybody, even because we know that people can be spreading it. The resources are not unlimited. Curative is still out there, as I mentioned before, but what are your thoughts on testing the vaccinated?
Are you asking me, Dr. Johnston? Yes. In an ideal world, we would all be testing daily, honestly. And that test would be a spit test, and the test would cost about 5 to 10 cents to manufacture. And I have to tell you, for whatever you've been paying for your rapid at-home test, I work with MIT on manufacturing rapid paper-based diagnostics. They don't cost more than 7 cents to make, and everything else is gravy for the companies. Just going to throw that out there. So in an ideal world, we actually could all afford that 7 cents to test every day, but we don't live in the ideal world. It is very hard to get enough tests. Everybody's seen the news, everybody's seen the lines. So the priority has to be testing symptomatic people, and then it has to be testing the people who are most likely to be infected, who remain the unvaccinated. So even though the vaccine is not as good at protecting against infection, it's still, especially if you're vaccinated and boosted, you still have about a 70% protection against infection. So if we want to put our money to the best use and our very limited resources to the best use, we're going to focus on symptomatic people first and then unvaccinated people second.
Thank you, Kathy. Amanda, do you want to say something about that as it relates to Aggie Health and Wellness?
Sure. Yes, that's exactly why the Aggie Health and Wellness has reverted primarily to becoming a symptomatic treatment testing site right now. Because we do have curative on campus, there's plenty of PCR tests to go around, and the rapid tests are the ones that are a little bit more difficult to come by. And that's the need from our community right now. So we are listening to your needs, and we are shifting our medical practices to ensure that we provide you what you're asking for.
Great. Thank you, Amanda. John, this one's for you. What are the current guidelines for working from home? If a school or daycare is shut down for COVID outbreaks, does an employee need to take leave? If we must quarantine due to a child's exposure, do we need to take leave? If so, what is the protocol for those who have no leave balance?
Thank you. It's a good question, but yes, the employee will need to take leave. The covered leave that was provided under the federal mandate expired in December 2020. Employees need to make sure they're working very closely with their supervisor, talk through this. There may be an opportunity for some of the teleworking depending upon your job, but if you're having issues with leave, reach out to HR, but you must all utilize what leave you do have.
Yeah, and talk to your supervisor if you don't have any leave and see what options there might be. Where can we obtain information regarding testing? I think we already said that Curative is in the parking lot of the main campus at Mesa, at the DACC Mesa campus, and in the community at various places that the other community colleges might be. So the second part of that question was, do you know the false positives and false negatives? How are COVID tests validated? Amanda and Kathy? Kathy?
Sure, I can jump in on this quickly. And to take a very big question and try to compress it to a brief answer. So the two properties that people care about with regard to tests are sensitivity, the likelihood of correctly detecting a true positive, and specificity, the likelihood of correctly detecting a true negative. And there, of course, are two categories of tests, the PCR-based nucleic acid tests, and then the rapid tests that detect protein or antigen. Now, the PCR tests have a sensitivity and specificity of about 99%. They're very nearly perfect. I suspect this question is more focused on the rapid tests, which do vary in their sensitivity and specificity. And there's also concern about fake tests being promoted out there. So I just sent Jon Webster a link to the FDA site that lists all the FDA approved rapid tests. So don't get anything that is not on that list. And then I also sent him a paper, it's 4 months out of date, which is ancient for COVID, but that went through a number of the evaluations of these tests and assessed their sensitivity and specificity. The rapid tests get better if you're symptomatic. They're less sensitive and specific if you're not symptomatic. But you can look in the paper, which I've asked John to post, you can look directly into PubMed, which is a clearinghouse for biomedical papers. You can look for your particular test and you can determine what its sensitivity and specificity is.
Thank you. Amanda, do you have anything else to add on that?
Mostly, yeah, if you're symptomatic, please use a rapid test. Don't take that test away from someone who is potentially symptomatic. They need it. They're very, very limited supply right now. So if you are asymptomatic, please get a PCR test and schedule out appropriately.
Thank you. Next question again is about masking and if we're going to be providing them. And as I said before, yes, we are. They're going to be free in the vending machines and in the classrooms as soon as they get here. And we've been told that should be by the end of this week, but I think we all know that there are supply chain issues everywhere. Make sure that you have a mask, which I'm sure that you do, and the surgical masks are better than the cloth masks. And you can also double up if you need to. Okay. There was a question about the dashboard, and I think I addressed that we had some issues with the new state reporting, and I had a hard time getting data out. It's very important that we have accurate dashboards, and we alert a variety of people if we can't be quite on top of it, but we are back on track at this point, and so you'll see a daily update to the dashboard. Okay, let's see. John, how exactly do unvaccinated people pose any danger to the vaccinated when the vaccinated can also transmit? What evidence do we have that the vax is working?
Thanks for that question. I'll probably ask Dr. Hanley to help with just a little bit of it, but what I want to talk about is what evidence do you have the vax is working? That's why I wanted to make sure that I pose that in our presentation with those numbers of hospitalization and deaths from the Seattle area. It's very clear to see that, you know, the vaccination, no, maybe it does not prevent you from getting the virus, but what it does do is it prevents you from that hospitalization and death, and the evidence is very clear on that. Kathy, did you have anything you'd like to add to that?
Yes, well, those hospitalizations are not without consequence, right? If you look at the situation in Oklahoma right now, the emergency rooms are all full, and Oklahomans are being told, if you have a heart attack, we may not be able to help you because our ERs are full predominantly of unvaccinated COVID patients. So in some ways, the unvaccinated are putting everyone at risk because of the high proportion of those individuals using hospital beds means those hospital beds aren't available for anything else. But as I mentioned earlier, although the vaccine is no longer really as good as it was at protecting against infection, and I don't want to soft pedal that, it still, if you are vaccinated and boosted, does an okay job at protecting you from being infected. And you have to remember that there are a lot of people out there, children under 5, the immunosuppressed, who are either can't be vaccinated or maybe vaccinated but not well protected. And so we want to do everything possible to protect those individuals too. And even if the vaccine is not perfect, you don't want to let the perfect be the enemy of the good. It's still good at protecting against infection, and so should therefore be used.
Right, thank you. And Kathy, one last one for you. Do you believe the CDC has lost credibility by continuously moving the goalposts and giving us always changing information?
Yeah, well, in fairness to the CDC and Dr. Walensky, it's really the virus that is picking up the goalposts, spray painting them, taking them out of the stadium and throwing them in a bonfire, right? And then scientists race to catch up to give the best scientific information. And then the CDC works very, very hard to implement that scientific information. And as much as it feels like COVID has been going on for 20 years, it's only been going on for 2. And a lot of the science is brand new and it is evolving. We're getting more and more data. And to my knowledge, the CDC is making a very good faith effort to try to implement that science while at the same time imposing the least burdensome practices that it possibly can on the population. So I think the CDC actually is improving in its credibility from early in the pandemic when it made some really bad missteps. I think it is actually doing a much better job now.
Great, thank you. And the last one before we move on to our presentations to John. I received a non-compliance notification, but I have an exemption request currently in process with OIE. What should I do to stay in good standing?
So first of all, you should continue to keep testing. Continue to submit those weekly testings to the VaxTrack. You may continue to receive those non-compliance report, but part of your OIE exemption request, as you'll note on OIE's website, requires you to consult with your supervisor. Your supervisor also receives those notifications. So with that, you can work through the non-compliance notifications with employee labor relations. Just note, people that were non-compliant by January 4th, and if you tried to submit exemption request after that date, you are non-compliant. That should have been submitted by the date of January 4th, which was our mandate final date to receive the full vaccination or request that exemption. So we are working through these as quickly as possible. The Office of Institutional Equity no doubt has received quite a few of these, and these are very specific, factual based that they must research and make sure that they are validated. So they are working through them as quickly as possible.
And supervisors are being alerted when people are non-compliant, and we're asking our supervisors to please work with the employees to do everything we can to keep our staff and keep them compliant. super, super important. And we want to thank everybody for doing so much and for struggling through Backtrack, which actually is pretty easy for some, but really hard for others. And, you know, we're a very compliant community and we really appreciate that. I'll come back at the very end, but it is 3:45. We've answered the questions that were sent in before 11 o'clock today. We will definitely get back in touch with those of you who submitted after we receive them a little bit later, so that we make sure that we answer and address your questions. And keep them coming. That's what we're here for. So I want to thank the panelists. You may all go away for a while or keep watching, which is what I'm going to be doing. And I'll turn it over to Lauren Goldstein. Lauren.
Hi, everyone. Good afternoon, and thank you for being here with us today. My name is Lauren Goldstein. I'm Organizational Development Specialist in the Office of the Chancellor. I work directly with Ruth, and much of my job is project management, facilitation, and collaboration. So I may have met many of you, and if I've not met you yet, I hope to soon in the future. Before I introduce our first presenter, I did want to take the time to say on our topic of mental health today that I started my own therapy work in the second year of my PhD at New Mexico State University. Part of my decision to go into therapy was because one of my professors talked quite frankly about it in class with us. And had I not made that therapist at NMSU Counseling Center was with me through graduation with my PhD. Had I not taken that opportunity, I can almost guarantee I wouldn't be in front of you here today. And it has definitely helped sort through the noise and figure out what to pay attention to in a world that's constantly evolving. Next, I'm excited to introduce my colleague, Jagdish Khubchandani. Jagdish joined NMSU's Department of Public Health Sciences as a faculty member in August 2020. What a time to be a new faculty member in the midst of a pandemic. His areas of expertise include clinical and social epidemiology, global health, and violence and injury prevention. He's published more than 125 research articles, received funding from a variety of agencies, and his work has been cited more than 30,000 times. His work also regularly appears in public outlets such as Washington Post and New York Times. One note I can say personally is Jagdish, during our Vax Tiger team work, our vaccine coordination, collaboration, rollout, and communication nexus that kicked off in January of 2021, Jagdish was an active colleague on the ground, literally, at the drive-through vaccination site on main campus, always with a positive outlook, a morale boost, and even for food, snacks, and drinks in those first weeks when we were coordinating for volunteers on the ground. Today, he's going to share insights from his recent research concerning the pandemic and facets of youth behavior related to mental health and well-being. With that, Jagdish, I'll hand it over to you.
Thank you, Dr. Goldstein, for the wonderful introduction. I hope you all can see my screen.
Yes, we can.
So quickly, as Dr. Goldstein mentioned, I joined NMSU in 2020. Before that, I was in Indiana, and before that, I was in India. So when I graduated medical school, the first job I took was in psychiatry. And within the very first few days and weeks, I realized that, how do you diagnose people with depression and anxiety? You take a general history and then you talk about mental health history and you ask a bunch of complicated questions, you assign a score. And it doesn't seem to be broadly applicable for mass screening, especially with young people in schools and colleges, because more than half of them worldwide don't seek mental health care. So once I graduated and I had my PhD, the first thing I did was I looked at how do you make these questionnaires into small questions, surveys that can diagnose people with depression and anxiety easily. So we had a breakthrough in 2015. We made a 4-question survey to diagnose depression and anxiety because both of them, in majority of the cases, occur together. And we found that our questionnaire had 75 to 85% accuracy if it was to be deployed in colleges and schools, which is a good bargain. We won't be 100% accurate, but at least we can reach out to more people. Instead of those 20-question surveys, we have 4-question survey. So since we had this breakthrough in 2015 with thousands and thousands of college students, we checked on their mental health history, their diagnoses and symptoms, and matched them how accurately our questionnaire could find if they had depression or anxiety. And then I started using this questionnaire in the pandemic, and I'll show you the questionnaire later. The first study we did was in July 2020. I know there was media reports that people are having mental distress, but in March 2020, when the president announced a national emergency, you couldn't expect people to have anxiety or depression overnight. So I waited till June 2020 so that the first lockdown passes away and see what's the extent of depression and anxiety in the US public. And we had 1,900 people from 50 states participate. 42% said they had anxiety symptoms and 39% had depression symptoms based on the questionnaire we used, which is a 4-question survey. And later the CDC confirmed that these numbers would seem accurate, that anxiety and depression in the United States have doubled or more than doubled. Who was more likely to be affected for depression? It was males. And those who are 18 to 25 years old, you may notice that this is the college student age group. Those who had household incomes less than 60,000. So clearly the group that was at highest risk of depression was the college age group, 3 times more likely than their counterparts. For anxiety, it was more females, Hispanics, those who had lower incomes, and 18 to 25-year-olds. Again, the college students had the highest burden of anxiety and depression. When we gave out our national questionnaire, these were the people most affected. And thankfully, thanks to NMSU marketing and communication, based on our confirmation of numbers in line with the CDC, there was widespread media attention to this issue. And then we started thinking, what are the causes for young people for depression and anxiety? And there's a whole spectrum of things, pre-existing mental illness. So almost 20% college students in the United States had anxiety, depression before the pandemic. Add to that a new number with more isolated people, fear of getting infected, death of family members, uncertainty about finances, jobs, grief, lack of control, disruption in life. Despite the circumstances causing depression and anxiety, the one thing that remained common was exponential increase in internet and technology use. And that's where I've been focusing more now with young people. Our second study was what kind of COVID information do you consume? Do you look at the numbers, cases, deaths, hospitalizations? So we sent a questionnaire to a random sample of 1,856 American people, all adults. Again, the anxiety rate was 42%, depression 39%. 49% Americans were seriously concerned about the quantity of information they were receiving, changing guidelines from government authorities, news channels floating around numbers of hospitalization and death, other types of social media sources. But more people across the nation were concerned about the quality of news. 64% people said they were seriously concerned about the type of information they're receiving. And it's proven multiple times now that there were so many flip-flops and changing guidelines and moving targets. So reflect on what affects you the most. Is it the quantity of news that you consume or the quality of news you consume? What we find in our study is that those who are concerned about the quantity of news and information they receive are more likely to be 18 to 25 years old, African Americans, those with low income and less than a bachelor's degree, which makes sense because these are the people who don't have the scientific background, the knowledge and awareness, and they're being confused by all kinds of information, and it creates a sense of fear. Those who have concerns about quantity of information on COVID being floated around worldwide are more likely to have depression, anxiety, or both, compared to those who have concerns with the quality of news, the fake news, the misinformation, myths, and rumors. Quality of information has nothing to do with depression or anxiety. So in summary, this national study has shown that the more time you're attached to the screen, the more likely you are to be depressed and anxious. You can limit your technology time, screen time, TV time. Even if you watch misinformation, myths or rumors, it won't affect your mental health. It's the time that you spend on screen that causes you to be anxious or depressed. Again, thanks to NMSU marketing and communication, this was a key study highlighted by many media outlets that you really have to cut down on your technology and screen time and limit it to a certain number of hours per day. And then finally, we wanted to refine our studies and look at technology and internet use. How much are we using internet and are we addicted? Again, we sent a questionnaire to 1,300 people across 50 states. The rate of anxiety and depression fell down 25%, 28%, because this was a study conducted in August 2021. So over the period of 1 year, as the CDC has also confirmed, there seems to be a decline in the rate of anxiety and depression in the US population, which is good news. But when we look at internet addiction, 45% people had no addiction, 41% probable addiction, and serious clinical addiction in 14% people. Before the pandemic, 10% American adults had serious addiction to internet, and now the number is 14%. Before the pandemic, most studies would say you are addicted or you're not addicted. We designed a special study by looking at no addiction, at risk of addiction, or serious addiction. Who was most likely to be affected? Those who had severe addiction happened to be in the age group of 18 to 35 years of age. People who live in urban areas, Asians and Hispanics. As you may notice again, it's the young people. And the US Surgeon General, Dr. Vivek Murthy, has issued an advisory in December 2021 that this could be the most lonely, isolated, technology addicted generation in America, 18 to 25 years old. So he issued a youth mental health advisory. Compared to those who had no addiction to internet, those who had probable addiction had higher symptoms of depression and anxiety, but not both. And when we compare no addiction group to serious addiction group, they had depression, anxiety, and both almost 10 times more likely to have those symptoms. So clearly, the more time you spend online, the more likely you are to have anxiety and depression. It's almost like a bidirectional relationship. People who are depressed or anxious try to withdraw, spend more time on Netflix, TV, radio, online, social media. And again, the study has been covered widely. And during the holiday season, I was asked in Voice of America, is this a special season? And yes, winter happens to be a special time with seasonal affective disorder, young people not knowing how to spend their time or being lonely, isolated in the dorm, at home. So this happens to be a special time for our populations, winter time, with a lot of holiday breaks and an upcoming spring break. My core recommendations today is that if you can please employ these short skills that we have designed, this is my current focus, to use all kinds of lengthy clinical diagnosis tools and make them shorter. The questionnaire that we have been using in nationwide studies only has 4 questions and gives you results with 75 to 85% accuracy. All that you do is ask 4 questions. Have you felt nervous, anxious, on the edge? How many days? You have not been able to control your worries. How many days? You have felt down, depressed, or hopeless. On how many days? And you have little pleasure or interest in doing things. Over the past 2 weeks, you add a score. And then you get to know if a person is seriously depressed or anxious and they need clinical diagnosis, therapy, and further support. We've also now focused on finding short questionnaires for internet addiction, problematic internet use, quality of life testing, the cage addiction questionnaire, which is used for alcohol use, that people want to cut down, they're annoyed by their habits, they have guilt, they need an eye opener. And think of technology as an alcohol type addiction where you wake up and the first thing you need is a cell phone. And that's the problem with alcoholics who are addicted. They need alcohol the moment they wake up, indicating a sign of anxiety and depression. So throughout the pandemic, we have been releasing through marketing and communication some tips. One thing that helps the most cut down on technology and improve mental health is maintaining a routine, waking up early, taking a shower, and having a set schedule and a calendar, going outdoors for biking and running, increasing physical activity, trying to avoid alcohol and drugs as they can worsen depression and anxiety. And sadly, they're related to technology use as well. People don't have to struggle in silence, find ways to help and support others. Volunteering helps improve your mental health. Practice self-care and listen to music, read books, and keep moving up and going out in the nature. I do think as an instructor, I was never trained to deal with mental health issues in students. So I acknowledge that vulnerability. Our PhD programs do not allow those trainings and teachings, but I did realize that we have to spend time to understand what anxiety looks like. I come from a family of many physicians, and some of them actually don't believe anxiety is real. It's hard for them to understand because they're trained in surgery and pediatrics. Use the classroom for stigma reduction. Don't assume that one strategy is equal for everyone. Be patient with students, help them think rationally, listen to them, respond to emails, and have a toolkit of resources that you can refer them to. Counseling centers, community resources, suicide helplines, or help them find out how serious their problem is. In one of my classes, I went one day and I just said, I'm not feeling okay today. I have such bad mental health today. And it's okay. And all the students started discussing their stressors. So we have to make sure that the students take care of their mental health, physical health, social, emotional, spiritual dimensions, have open discussions. Don't be afraid to ask for help. There's no controversy in students seeking mental help from you and you referring them to an appropriate agency. Be flexible, try to reduce the amount of fear students have. I'm always amazed by how many students don't even want to write an email because they're scared. And so maybe we take the lead and keep sending those weekly reminders. Also have some mechanism to find out if someone is struggling, failing. Maybe they are dealing with a mental health issue and need special attention, and you reach out to them. Before I end my presentation, I hope that you can look at the American Time Use Survey, the latest one that came out, which has indicated dramatic rise in technology, internet use in young people, spending more time online, gaming, gambling, on movies, social media. So the dramatic rise of technology use has also been related to mental health issues. And for your reflection, how many tech devices do you all have and how much time do you spend online? I'm positive that you have spent more time online today than before the pandemic. And that's one thing that I wish you take from here, that people have to cut down their technology use and set that reminder for the students as well. And that's it. Thank you.
You're muted. You're muted.
Thank you, Ruth. It happens to the best of us. Thank you, Dr. Khubchandani, for that presentation, and definitely the stark contrast or comparison between alcohol addiction and online addiction certainly gives me something to think about. Thank you again for your presentation today. Next, our next presentation will be from our colleagues at HelioCampus. So New Mexico State University is part of the HelioCampus Consortium, comprised of 80 member institutions in 35 states and Canada. My colleague Ermelinda Quintela and I have been working with HelioCampus closely for the past several years. And through our collaboration, we've fostered a really robust relationship with Helio. We meet weekly and triangulate our data benchmarking results with units across Strategic System Services, which is the Vice Chancellor's office, to maximize our insights into NMSU data and trends. We've also gone forth with this with great intentionality and collaboration with service units to use Helio data and departments' existing data to shine a flashlight into potential areas of opportunity for administrative operations. As Kyle, who is the client services manager, will tell you, we also have a fair bit of fun working together. So I'm glad to welcome today Mr. Steve Beiser, VP and co-founder of HelioCampus, Dr. Jagdish Khubchandani, Director of Research at HelioCampus, and Dr. Kyle Salvaggio, Client Service Manager at HelioCampus.
Thank you, Lauren. I'm Steve Beiser, one of the co-founders of the Benchmarking Consortium, and I'm dialed in from my office in Chapel Hill, North Carolina. I'm also a professor of the practice at the King and Flagler Business School at UNC Chapel Hill. We began in 2014 as a standalone organization called the Academic Benchmarking Consortium. We formed the consortium to address the growing need for staffing benchmarks within higher education, since the spend on people who work for institutions of higher ed typically represents 60 to 70% of the annual operating expense. UNC Chapel Hill agreed to provide the initial seed funding to start the consortium, asking us to focus on the people spend for the administrative activities required to run the university. In 2020, we had grown to 50 member institutions and decided to seek a partner who had experience analyzing faculty staffing data, as our member institutions were requesting that we provide benchmarks beyond just the administrative activities. In July of 2020, we decided to join HelioCampus, an organization who has deep expertise in this area. HelioCampus is a data analytics organization whose roots are with the University of Maryland. You can see from our membership map that we now support 80 institutions, the dominant profile being large and medium-sized public institutions, such as New Mexico State University, who joined in April of 2020. Each year, our member institutions submit their annual fiscal year payroll information to us. Our team maps it into our standard activity model, which covers 10 different activities, such as finance, IT, human resources, and student services. We then provide a curated insights report that shows the relative staffing levels across our institution. Members can also conduct their own analyses using our online benchmarking platform. Additionally, we also conduct research on topics important to our member institutions. Dr. Jagdish Khubchandani, who heads up our data services and research group, will now present a summarized version of our latest research on trends in student mental health and wellness staffing. Ranjini?
Thank you, Steve. What I'd like to do first is to share some background information about the mental health crisis for college students across the country. After we share some of that background contextual information, what we'll do is to share some research from the HelioCampus Benchmarking Consortium on trends in student mental health and wellness staffing for our member institutions in the consortium. As we're all aware, student mental health is a crisis that has been developing prior to COVID-19. The mental health needs of college students have been steadily increasing over the past decade. 1 in 3 college students report having a mental health disorder. 1 in 4 take psychiatric medication, and the rates of major depression have more than doubled between 2009 and 2019. The student mental health crisis has only been exacerbated by COVID-19. We've accumulated here some statistics to highlight this. In the fall of 2020, about 1/3 of mental health visits were related to the pandemic. 72% of students seeking mental health services reported that their mental health had been negatively impacted by COVID-19. And institutions have been responding to the increased needs of their student populations. Students seeking mental health help received an average of 20% more services as compared to the fall of 2019. This has certainly, of course, been the topic of national conversation. With the bipartisan introduction of the Higher Education Mental Health Act of 2021, Congress has certainly taken an interest in better understanding the mental health needs of students and providing guidelines at the federal level. Of course, with all of the mental health issues that college students can experience, this certainly has an impact on student outcomes. Students with mental health problems are twice as likely to leave an institution without graduating, even after controlling for a prior academic record. When you look at students with mental health problems, 25% of low GPA students with mental health problems dropped out, while only 9% of low GPA students without mental health problems did so. And these effects will only be multiplied by the surge in the pandemic-related mental health issues. We focused thus far in the background on the mental health crisis amongst college students, but there is certainly an impact for employees that are in our campus health clinics, servicing students and providing mental health and wellness services. College and university mental health clinics have been seeing an exodus of mental health professionals, including at the director level. Institutions have been having and facing challenges recruiting and retaining experienced clinicians. There's burnout for staff. Counselors have been requesting part-time positions and medical leaves to address their burnout. And there are, of course, the risks and the potential for negative consequences when you have burnt out counselors working with students in crisis. So what we did with the data that we have from our members in the HelioCampus Benchmarking Consortium was to investigate what we can see from the data in terms of trends in student mental health and wellness staffing across the institutions that are in our benchmarking consortium. Well, we asked a series of questions of the data. And first, what we did was to actually survey our members in the consortium in order to gain information, to gain insights from how our members in the consortium have been dealing with the student mental health crises on their campuses. And through that, we learned that there are a number of different initiatives that our member institutions have undertaken where they are starting to see some positive impacts from those initiatives. What we've done on this slide, and we'll return to this slide at the end of our presentation as well, what we're doing here is just showing you at a high level, what are the 4 main questions that we asked of our data, and what are the high level answers that we found as a result of the data. The first question that we asked is, how have members been responding to the growing student mental health needs on their campuses? And here, as I mentioned, we surveyed our membership, and what we learned was, perhaps unsurprisingly, student mental health was a hot topic across most survey respondents. Many universities have been increasing their student mental health and wellness staffing prior to COVID-19. And as I'll share in a few upcoming slides, we also learned some more specifics about certain types of initiatives that our members have undertaken and where they are starting to see some positive effects on their student populations. The second question we asked was, how do members' spend and staffing levels for student mental health services vary across our benchmarking consortium? As Steve mentioned earlier, we have a number of different institutions that are in our benchmarking consortium that vary across a number of characteristics. We have small institutions, large institutions, we have private and public. So what we did in our data analysis was to divide the institutions in our benchmarking consortium into different groups based on a few different characteristics. The operating expenses, the magnitude of the operating expenses of the institutions, the size of the student population, and the magnitude of the research expenses, or put another way, the intensity of the research happening at the institutions. So we came up with a few different size categories, and what we found was that in fiscal year 20, which is the most recent year of data where we have the largest sample size, what we found was that the smallest institutions in our consortium invested the most in student mental health and wellness, labor spend, and FTEs or staff, with smaller institutions investing the least. The 5 groups that we have large institutions, mid-size high research, mid-size, smaller, and smallest institutions. Those were the findings for fiscal year 20 for a single year. But what we were interested in next was investigating what the trends were over the past 3 fiscal years. So from FY18 to FY20, how have institutions been responding in terms of their labor spend and their staffing when it comes to student mental health and wellness? What we found here was that large and smaller institutions have had the largest increases in student mental health and wellness labor spend and FTEs from FY18 to FY20. And the final, and perhaps the biggest question that we asked of the data was, is there a relationship between student mental health and wellness labor investments and student outcomes? As you can imagine, given the relationship between student mental health issues and the impacts that there can be on student outcomes, this was of primary relevance. And the short answer is that yes, we did find a positive relationship here. Higher student mental health and wellness labor spend was associated with higher student retention rates, although this is a very complicated question with a very complicated answer, and there are likely many factors at play, and we'll go into what some of those factors might be later on in the presentation. So I'll start here with this first question: how have members of our HelioCampus Benchmarking Consortium been responding to growing student mental health needs on their campuses? As I mentioned, we administered a survey to our members, and one of the questions that we asked of our respondents was, which initiatives that your institution has undertaken to support student mental health have had the biggest impact? And this was very illuminating to see the types of responses that we got. Certainly with the pandemic, we see that there's been a rise in online telehealth services and platforms. Some institutions indicated that they've seen some success with additional counseling staff and spend to cover additional hours. Some institutions have attempted group counseling sessions and seen some positive impacts. Some have been partnering with local agencies to supplement services. Some have generally just been expanding and increasing their services. Some have been adding case managers to their staff. Some have been embedding counselors in high-risk areas and in colleges, so out in the academic units. And we've also had some institutions respond that they've been using wellness initiatives and coaching, including a peer education model, with students sometimes being the first line of defense for other students that are in crisis, equipping the students to be able to have the resources to refer students in crisis to relevant and appropriate services on campus. In addition to the data that we collect from our members in the benchmarking consortium, I also want to highlight that we are a community of members as well. And we certainly encourage and help facilitate connections between our members so that they can knowledge share with each other, share different perspectives, share learnings. And really, it's this knowledge sharing and learning that can be really effective for institutions in order to get ideas in terms of how other universities are tackling similar issues that they're all facing on their campuses at this time. With COVID-19, certainly student mental health is a key priority for institutions across the country and in our benchmarking consortium. Of course, there are several other challenges that institutions are tackling as well. And so we asked our membership what some of the other challenges are that they are facing, and some of the responses that we received are in response to the question, what are some top priorities at your institution in budgeting and resource allocation conversations regarding COVID-19? We received responses indicating contact tracing, testing, vaccinations, and PPE, student enrollment levels, employee compensation and benefits, hybrid teaching capabilities and online education accessibility, funding for auxiliaries and budget reduction, of course, the topic at hand today, student mental health support and crisis management, and just simply keeping up with the demand, in addition to student mental health and wellness, employee wellness, and also filling staffing vacancies. So those were the results from our survey. What we did next was to look at the data that we actually collect from our members in terms of the labor spend and the labor FTEs across various administrative areas, and the data that we have on student mental health and wellness staffing. And the question that we asked of the data was, how do members spend and staffing levels for student mental health and wellness services vary across the consortium? So what we did at a high level was to take all of the titles that are providing student mental health and wellness services to students. We looked at the labor spend associated with those titles. We looked at the FTE levels associated with those titles. And then we compared institutions across those different size categories that I mentioned in order to see what kind of trends emerged when we looked at FY20 data. So these are the results that I'm showing you here. The graph on the left is showing you spend. The graph on the right is showing you FTEs. You'll see here that there are separate orange bars for each of these size categories that I mentioned for our institutions in the benchmarking consortium. You'll see that there are large, mid-size, high research, mid-size, smaller, and smallest institutions. And in this data set, given that New Mexico State is a member of the benchmarking consortium, New Mexico State is one of many members in this data set. And what we found here when we looked at spend per student, as well as FTEs, student mental health FTEs per 1,000 students, is that the smallest institutions had the highest investment when it came to labor spend and FTEs for student mental health and wellness, compared to the other size category institutions in our benchmarking consortium. So that was for a single fiscal year for FY20. What we did next was to look at the data to see what are we seeing in terms of trends across time. So how have student mental health staffing levels changed over the past 3 fiscal years from FY18 to FY20? So first, we looked at total spend on student mental health and wellness. And that's the table that you're seeing on the left. The table on the right are total FTEs for student mental health and wellness. And you can see here there's a separate row for every size category for institutions in our consortium. So what we see here is that across all of the size categories, institutions increased their spend and their FTEs when it comes to student mental health and wellness from the time period from FY18 to FY20. And just to give you a sense of order of magnitude, we can see that our large institutions on average increase their labor spend on student mental health and wellness by about $1.2 million. They increase their FTEs by about 11 11 additions to their staff. And down to the smallest size institutions, you can see on average, they increased their spend on student mental health and wellness by about $94,000. They increased their FTEs by about 1.5 FTEs. What we wanted to do next was to normalize by the student population at our institutions in the benchmarking consortium. And these are the data that you're seeing presented here on this slide. On the left, what we have is a line chart where every line represents a different size category of institution within our consortium. So we have the large institutions shown in orange. You can see the mid-size high research, the smaller institutions in dark blue, and the smallest institutions in black. The general trend here, all of these lines are trending upwards, again, indicating that institutions in general have been increasing their labor spend on student mental health and wellness. And here we're seeing it on a per student basis. The table on the right is showing you on average for each of these size categories, the average spend on student mental health and wellness on a per student basis. And here you can see the FY18 to FY20 compound annual growth rate to give you a sense of the annualized growth from FY18 to FY20. What we see here is that although all size categories of institutions have generally been increasing their investments in student mental health and wellness per student, we see that the large, smaller, and smallest institutions tended to have the largest increases over this time period. Here, this next slide is showing you the same sorts of results, but now instead of looking at labor spend per student, we're looking at FTEs per student. Again, student mental health and wellness staffing on an FTE per student basis. And again, we see a similar trend here. For all of the size institutions within the consortium, all of these size categories, generally we see that these lines are all trending upwards. Institutions in general have been increasing their staffing when it comes to student mental health and wellness. But we do see that smaller, large, and the smallest institutions in the consortium tended to have the largest increases over this time period. Next, we look to see what the compensation trends have been over this time period, or in other words, labor spend per FTE from FY18 to FY20. So here, what we're seeing is the labor spend per FTE for each of our institution size categories. And what you can see with the table is that the large, mid-size high research and mid-size institutions have tended to see an increase in compensation or labor spend per FTE when it comes to student mental health and wellness from FY18 to FY20, while our smallest and smaller institutions have tended to remain relatively steady and even seen slight decreases in this compensation over this time period. The final question that we asked of the data was, is there a relationship between student mental health and wellness labor investments and student outcomes? And here, when it comes to student outcomes, we focused on student retention rates as a student outcome metric. Specifically, we were looking at the full-time retention rate, that is the percent of fall 2019 full-time first years that remain enrolled in fall of 2020. So what we did was to look at the relationship between that retention rate and the labor spend per student and the labor FTEs per student when it comes to student mental health and wellness staffing. So that's what we're showing you here in the scatter plots, and I'll just break down these graphs for you. The x-axis here represents on the left the FY20 student mental health and wellness spend per student. The y-axis represents the fall 2020 retention rate. You'll see a similar scatter plot on the right, where here the x-axis is the FY20 student mental health and wellness FTEs per 1,000 students. The y-axis continues to be the retention rate. Every dot here represents an institution in our benchmarking consortium, and you can see they've been color-coded by those institution size categories. The main takeaways from this slide, the main point to convey is that we are seeing a positive relationship, a positive correlation between higher investments in student mental health and wellness staffing when it comes to spend and FTE. We see a significant correlation here, a positive relationship, but non-significant correlation when it comes to FTEs. So the higher the student mental health and wellness spend per student, the higher the retention rate. But we do want to highlight here that, as I mentioned earlier, retention and student mental health, very complicated, very tricky areas, likely many factors that are at play. And with the institutions that we have in the consortium, they vary across a number of different characteristics. We looked at size in terms of student population, research expenses, operating expenses as some of the dimensions along which we can analyze the data. There are many other dimensions, including student population characteristics. Here we've highlighted a few. We've looked at the selectivity of institutions and the standardized test scores of the student population. And what we can see here is that there's a high degree of variability in terms of the selectivity between different types of institutions, as well as the standardized test scores. So we do want to emphasize that retention rates are likely related to several factors, one of which may be student mental health and wellness services. And institutions may have data on students who do not return to the university. And those data can be a rich source of information, particularly in providing insights in terms of what types of services may be most impactful with moving the needle on retention. There are many different types of services, academic services, non-academic services. And for the institutions that are in our consortium, we do hear, from our institutions that some of the questions that the institutions are asking are, what are the right types of services to be investing in? What is the right amount of student mental health and wellness staffing to have on campus? And there are many sources of data to bring to bear to try and address these questions. Certainly the benchmarking data, knowing how much an institution is investing in student mental health and wellness, and benchmarking to other similar institutions can be a valuable source of information. But really the community aspect of our benchmarking consortium as well, the knowledge sharing, gaining information and perspectives from other institutions, and learning about how they have been handling the student mental health crisis on their campuses can be important sources of information as well. So here I just want to come back to our summary of key findings slide. The first question we asked was, how have members been responding to growing student mental health needs on their campuses? We find from the members in our benchmarking consortium that there are a number of initiatives that they've been undertaking to address student mental health needs on their campuses, some of which have been meeting with positive reception and positive results on their campuses. When we look at the consortium data in terms of labor spend and FTE and how that varies across the consortium, we find that in FY20, the smallest institutions in our consortium invested the most, smaller institutions invested the least. We find that institutions in general have been increasing their student mental health and wellness investments when it comes to labor spend and FTEs from FY18 to FY20. We find that, yes, there does seem to be a relationship at a high level between student mental health and wellness labor investments and student outcomes, but likely many factors at play. And I do want to mention, much of this data that we're looking at is, from FY18 to FY20. Certainly this is a topic of research that we plan to carry forward FY21 and beyond to further investigate and learn what the data can tell us. So with that, I'll turn it back to Lauren, and thank you for the time today.
Thank you so much, Dr. Khubchandani. And thank you again to our HelioCampus colleagues on the East Coast joining us from another time zone. Thank you so much. And thank you everybody for being here today on the town hall. And with that, I'll hand it back to Dr. Johnston.
Thank you very much, Lauren, Helio colleagues, Jagdish. Thanks very much for a very interesting and need to follow up on presentations. Lots of good information here for us to be thinking about as we support our students and our faculty and our staff. This is a really tough time for mental health. Well, I hope for those of you who stuck through to the end that you got something valuable out of this. John has continued to get some questions. We will be sure to get responses to you as soon as we possibly can. May need to triage a few of them. But I just want to leave with a few words now that we're starting to get a little bit of rain and it's starting to get a little dark, that we are starting into spring semester. It's middle of January. We've got a whole semester to go. So we'll see you again on February 15th for the next town hall. And be positive as much as we possibly can. I think our students, our staff, our faculty, they all look to us to be the most positive we can in a tough situation. Be nice as much as you can to each other. Take care of yourself, take care of others. Wear your mask and go Aggies. Thanks very much. Have a good rest of the week.